So thank you. I'm going to talk to you now about how much cancer is due to hereditary factors and what can we do clinically about that when we make these genetic tests. I have no conflicts to declare. So the most robust statistical answer to this question is provided by the Scandinavian twin registries. 200,000 fraternal and identical twin pairs where we can look at the concordance of the disease, any disease, in this case cancer, and showing this heritability proportion. You see it ranging from 15% for colon, breast 31%, prostate cancer coming in at a whopping 57, almost 60% of prostate cancer with a heritable component. And that's all higher numbers than I just showed you in our modification of Graham-Kolditz's slide. Why such large numbers? Well, what we're learning is that cancer is due to not only these very highly penetrant, high-risk associated but very rare genes, the ones on the top left that you all are familiar with, but also these common polymorphisms, the SNPs at the lower right. 20-40% of you will have some of these, but their risks are 1.1, 1.2. The risks here are 40-fold. And it's this polygenic combination that drives this inherited risk. Now, there's also a group of mutations that we see in certain groups, founder populations. I discovered this one in BRCA2 in the Ashkenazi population, and here we have an order of magnitude greater frequency in some of these genetic isolates. And also in Iceland, there's another group. Well, the efficacy, this is the canonical example of the BRCA genes. If you have a high risk, you can intervene. We intervene surgically, as you'll hear for most of these syndromes. We wrote the first prospective study of oophorectomy in this group, finding 4 out of 100 women had microscopically curable ovarian cancers. We predicted this would be good for mortality. Susan Domchek and others confirmed a 70% decrease in mortality in BRCA carriers after prophylactic ovarian surgery, risk-reducing surgery. The Angelina Jolie breast option, mastectomy, is only about 20% in this country. More women will elect for MRI, finding this tumor missed on mammography, tamoxifen. And if we miss the cancers at early diagnosis, we can catch these with treatment that's specifically effective, the PARP inhibitors against HR-deficient pathways. So this is a list of the syndromes that I see on a regular basis. And as I said, we're doing a lot of surgery still in the 21st century for these syndromes. We combine these with targeted therapies, pathway-specific, increasingly, for these syndromes. But shown here in red are the surgical interventions. We're taking out stomachs, kidneys, colons, breasts, and ovaries. Colon, you'll hear a lot more from Ernie. I'll just say here that colonoscopy is great and can actually prevent these cancers. And you'll hear a lot about immunotherapy. I just want to mention that in these hypermutated tumors, we do see germline mutations of Lynch syndrome, but this doesn't look like Lynch syndrome the way we teach it to our students. Here's urothelial and bladder cancers. These will respond to this type of checkpoint blockade, and these are Lynch families. So in these patients we're treating, we're going to be preventing cancers by doing colonoscopic screening. And this is the FDA approval, and Ernie will give you an interesting preventive application of that approach. Here's something you may not think about, but medical geneticists, pediatricians, so BGs know that if we find a mutation, so this is a family we discovered with leukemia due to a transcription factor. You can't target or treat a transcription factor, but what you can do in a family like this is offer them targeted reproductive options. So you can take a cell out at an 8-cell embryo, leave 7 cells with no mutation that you're seeing from PCRing the first, put that in, which makes a child, and that child does not have the mutation that the parents. We do this. It's done at major cancer centers in referral, and these are families where we can stop the line of genetic inheritance. Here's a family that has inherited breast cancer but no BRCA mutation. It has a mutation we discovered in a nucleotide excision repair gene. This is an Ashkenazi founder mutation. Here we can functionally show that these cells are exquisitely sensitive to this compound, a sesquiterpene. But there's a drug, and we actually can give this drug to mice that we have put in a genetically engineered RAS overexpressing tumor. And as Laurie said, this is the first one for me, curing a cancer in a mouse. Look forward to checking this in humans that have these germline mutations in this nucleotide excision repair, showing the transition or translation of the germline. Well, our screening studies now are giving us another idea of the amount of heritable cancer. We're doing this in cancer centers by screening tumor normals at huge numbers. This is the first 1,000 of 10,000 done, and I would point out that 17.5% of advanced cancer patients at our center had actionable germline mutations. It's a very high number. That's where that number comes from the first in Otis's slide. Half of these we never would have predicted clinically, and interestingly, they're predicted not only by ancestry, which I mentioned, and the type of tumor, but also the stage. The more advanced tumors have advanced stage. Here's another approach to cancer screening. We should have done this 20 years ago. We're doing this now in the Ashkenazis, 3.5 million in this country as a pilot. How can we actually do population-scale genomics and involve the medical establishment? So this isn't direct-to-consumer. Yes, it looks like it because they'll get it online for free, and this study is open, and if you have patients or colleagues of Ashkenazi ancestry in any of these cities, the study is running, but they need to get the results from a physician or one of us, and these are the organizers. Didn't want to go too quickly. Can't go back one. Anyway, the organizers of the study are listed at the bottom, and they are Beth Carlin, who's in the room, Susan Domchek, recently elected, Judy Garber, and a group of us in New York, Philly, Boston, and LA. There they are. I wanted to be sure that they got their due. And there's Beth. So while we've been doing this carefully, the commercial companies have moved ahead as well. This is a sort of fashionable spit party that happened in our city not long ago with a number of characters here who are familiar to you. And what this has raised, some of these controversial, has raised some controversy as well. Many of these tests have not reproduced this article in the Times about certain ancestry findings, and this raises larger issues that we may discuss. These are my opinions, not those of my institution or the academy. I'm concerned about some of the conflation of empowerment of individuals versus financial sort of economic exploitation, false results, false reassurance, uncertain variance, privacy, the important role of our federal agencies, and I would say the important role of our professional societies and perhaps this academy and other academies in ensuring the safety of these public health genomics exercises. So this is the conclusion, that the burden of hereditary cancer is larger than we had anticipated initially. In that range I just showed you of about 17 to 18% in advanced cancer patients. Hereditary cancers offer the opportunity for precision prevention as well as targeted therapy. And as such, testing for hereditary cancer is a medical, I would argue, and not a recreational endeavor, despite this New Yorker cartoon that shows the folks in Beverly Hills or the Hamptons, I can't quite tell where, getting their DNA done. And Judy Garber and I noticed that there's a base pair mutation in the New Yorker, very unusual, and maybe that tells us what to look out for. Thank you very much.